Hello, I'm Eric Strong from Strong Medicine, and today I'll be discussing how to work with a medical interpreter. This video will be framed as if English is the primary language in the country in which you're working, but if it's not, the same principles apply. The first thing to address when working in a clinical environment: how do you determine if an interpreter is necessary? Sometimes it's obvious. You need to take an H&P on a new patient, they speak no English, and you speak none of their own language. Or they speak no English, but you completed your medical training in the country where the patient is from. In other words, you're not just fluent in the language they speak, but you trained in the language they speak. But it's not always that obvious. Overall, you should clearly err on the side of getting an interpreter, but at least in acute inpatient settings, getting a trained interpreter for every single encounter with a patient who lacks complete English fluency is not always practical. So how do you decide? Considerations include how much English the patient speaks and understands. In the case of bilingual clinicians, how much of the patient's language the clinician speaks and understands. Keeping in mind that your medical facility may have a formal program by which they test a clinician's language proficiency before condoning care being provided in a language other than English. The complexity of communication, for example, are you having a goals of care discussion, or are you just assessing whether their headache from a few hours ago is now improved? The availability of an interpreter. In many jurisdictions, including all of the United States, medical facilities are required to provide some form of interpretation services. But that does not mean that interpretation services will always be fast or practical to arrange in every circumstance. Finding a trained interpreter for some dialects and languages can take hours. And in my experience, the harder it is to find an interpreter of a particular language, the lower the apparent quality of interpretation. Another consideration is the urgency of communication. If you're in the middle of a rapid response call for acute dyspnea, there may not be time to track down an interpreter before you need to assess the patient. And last, any request by the patient or family for an interpreter should be honored. What are the options for an interpreter? In all circumstances, the best option is an in-person trained interpreter. Trained interpreters can also be used on video calls or on the phone. Some hospitals are large enough to employ their own staff of trained interpreters for common languages. For smaller facilities and for less common languages, the facility must contract with a third-party company that provides interpreter services by phone or video. Another option is untrained bilingual staff. A family member or friend, keeping in mind that minors can only be used for interpretation in emergencies when there are literally no other options. And last, there is always Google Translate or similar software. However, such software is generally not HIPAA compliant, so do not include protected health information, including the patient's name. What are the differences between some of these options? Let's compare a trained interpreter versus an untrained bilingual staff member versus a family member interpreter. Trained interpreters are reliably accurate, while for untrained interpreters, accuracy will be variable. In particular, family are often unable to interpret medical terminology. Trained interpreters will interpret everything that's discussed, including parts of the conversation that occur between medical team members that they may not even intend to be interpreted for the patient verbatim. Untrained staff will generally interpret everything that's meant directly for the patient and nothing else. Family interpreters often just summarize. They may answer questions for the patient, and they may deliberately leave out uncomfortable information, and you will have no way of knowing that they've done that. For example, if a patient tries to volunteer to you drug or alcohol use or other high-risk personal behavior, or if you are trying to convey a sensitive or serious diagnosis, the family may shield the patient from hearing it. Neither trained nor untrained staff interpreters will engage in side conversations with the patient, but this is very common with family interpreters. Trained interpreters maintain neutrality and confidentiality. Untrained staff interpreters usually maintain neutrality, but consistently maintain confidentiality. But neither of those things should be assumed with family interpreters. I hope this table illustrates why trained interpreters are better than untrained staff interpreters and are much better than family interpreters. Some patients will prefer a family member or friend to interpret, even if a trained interpreter is available. Whether you should insist on using a trained interpreter nonetheless depends on the situation. If it's a goal of care discussion, or if we'll be delivering bad news about a diagnosis, I will very strongly encourage the patient to use the professional, but they ultimately have the right to decline. Once an interpreter is chosen, before the conversation starts, you should briefly consider how to arrange the room. There's several options. The one which I think is the worst is to have the clinician on one side of the patient and the interpreter on the other. The patient will either be constantly looking back and forth or will only make eye contact with the interpreter, which is not ideal for establishing a trusted clinician-patient relationship. A better arrangement is to have both the clinician and the interpreter side by side, either on the same side of the bed or at the foot of the bed. This arrangement is necessary for sign language interpreters. Otherwise, the arrangement that I personally think is the best is for the interpreter to be right up at the head of the bed, almost out of view of the patient, which forces the patient to maintain eye contact with myself. This reinforces the role of the interpreter as a conduit for information, not as an active participant in the conversation. This minimizes the patient's tendency to initiate side conversations or to mistakenly see the interpreter as an ongoing member of the core medical team. Now is the time for the actual conversation to begin. Some general tips. Maintain eye contact with the patient. Use a normal tone of voice. Speak in relatively short segments. You don't need to use only detached, simple sentences, but you should not be talking for more than 10 to 15 seconds or so at a time without taking a pause for the interpretation. Use first-person language. For example, ask, "Are you currently experiencing chest pain?" rather than, "Can you ask him if he's currently experiencing chest pain?" If using an untrained interpreter, including bilingual staff, avoid medical terminology since there's no guarantee they can accurately interpret it, even if they are otherwise fluent. Avoid idioms that might not have an obvious equivalent in the patient's own language. And last, for any encounter using an interpreter, you need to anticipate that it will take twice as long as one without. If you enter the room already expecting and planning for that, you won't feel as rushed. Finally, the use of an interpreter should be included in the documentation. And if an untrained interpreter is used, the reason for doing so should also be documented.